You're listening to the Doc Lounge podcast. This is a place for candid conversations with the healthcare industry's top physicians, executives, and thought leaders. This podcast is made possible by Pacific Companies, your trusted advisor in physician recruitment.
Welcome back to the Doc Lounge podcast. I'm your host, Stacey Doyle, Senior Director of Marketing here at Pacific Companies. Today, we're diving into the business side of healthcare innovation, how great ideas actually make it to market, with someone who truly knows how to bridge that gap. Rachel Strauss, CEO of PBM Princess, LLC. Rachel is a powerhouse in the world of healthcare consulting and pharmacy benefit management. She's built an entire ecosystem of clients around three simple but ambitious goals: making healthcare more affordable, accessible, and collaborative. With over 2 decades of experience in health insurance and PBM strategy, Rachel is known for helping companies refine their message, position their products, and connect with the right partners to drive real change. As employee number 11 at EHIM, she helped grow a regional PBM into one of the top 20 in the nation, and she's been transforming organizations ever since. In this episode, we'll explore her journey from top sales executive to founder, her insights into the evolving payer landscape, and how she's helping startups and innovators get their solutions in front of the people who can actually make things happen. Let's jump in. Welcome to the podcast, Rachel.
Thank you, Stacey, for having me. I'm excited to be here.
I'm excited to learn more. Well, tell us, it sounds like you've had quite a dynamic career. Tell us a little bit about your evolution and where you are today.
Absolutely. So, most people, Stacey, don't understand. Even I loved that you accidentally said PMB because it's just not an acronym that rolls off your tongue, which leads me to believe you probably prior to today not heard of a PBM. Would that be correct?
Correct.
So a PBM, just to kind of educate the audience, most of your providers listening will probably know this term, but a PBM stands for Pharmacy Benefit Manager. And a PBM is the component of the payer side of healthcare that processes prescription drugs. So 95% of every prescription drug that is processed in this country today is in some way touching a PBM. So you're talking about from the insurance side, you're talking about from the patient side, you're talking about the physicians who are writing prescriptions and needing to get approvals. It is coming from a pharmacy benefit manager. The industry as a whole has this, reputation of being middlemen in an industry, essentially connecting the pharmacy as a network, right? So if you go to CVS, Walgreens, or your local mom and pop, to the payer, which is, in many cases a carrier like a Blue Cross, a United, or a Cigna, or an Aetna. I know you're in California, so like a Kaiser, with the mechanism for the patient to pick it up. So when you get a prescription, you usually have a copay, or if you're on a high deductible health plan, you're paying maybe the first dollar, but it's not all the drug costs, right? There's some other component behind the scenes in health insurance that is telling the pharmacy what is your responsibility and what is someone else paying the pharmacy back for that cost of good. That's the world I live in.
Fascinating. Okay.
Yes.
Thank you for educating everybody about that acronym. I love that about your branding, because the company name that you have is PBM Princess. So tell us about that.
Yes. So, I've been in this industry more than 20 years. And to me, it sounds boring when you first think, oh, I work in health insurance. Oh, I deal with pharmacies. But this is touching everybody who ever has a prescription, everybody who's ever talked about the price of a prescription. And in the last 10 years, you're hearing it more and more. And because I wore a lot of pink, and which I'm not today, I have pink eyeshadow on. So I guess we'll count that for those of you who are watching this live and not listening to the podcast. But because of the pink, and because I'm a woman in this industry, Stacey, which there weren't a lot of women when I started, somebody said it as a joke that I'm like the princess of the PBM industry. And I'm like, you know what? Do I hate it? I kind of don't hate it. I don't know if it's a compliment, but I'm going to just run with it. And, I've just decided, we talked a little bit about LinkedIn, before we started, and just the power of LinkedIn. during the pandemic, I did a lot of podcasts, and somehow, before I knew it, I had 10,000 people following me. And then that number today is, growing upwards of 16,000. And then when I started adding all of the different media channels with TikTok, I started becoming known as a LinkedIn influencer in this space. And actually, I'm wearing a t-shirt today. It's backwards on my computer, but it says, "Do I know you from LinkedIn?" Because that's like what I get. I'm actually right now. I'm leaving Buffalo, New York, where I spoke at a Rev Cycle conference, which was for the hospital industry. So I'm sure many of your listeners will have heard of HBNA. And the irony is that people here today did not know who I am because we don't cross paths, we don't cross the aisle. And why I started PBM Princess was because we have to. People like yourself need to know the term PBMs because it's part of what is affecting the cost of healthcare in America today. Providers need to understand, who is paying them. We all, we're at a Rev Cycle, conference, which is focused on hospitals and providers getting paid quickly so they can pay doctors and continue to use Pacific to hire people, right, and grow. But the problem is people don't know, like when you say payer, who is paying in this, circumstance? Most people just assume, oh, it's Blue Cross, it's Kaiser, it's whomever. But who pays them? And that's the world that I bridge. It's employers who give people health insurance. It's individuals in the ACA, buying insurance and needing to understand how it works. And if we can figure out how we all communicate, that's how we're going to fix healthcare.
Well, this is a topic that, couldn't be more timely. And it's one that we've had on our podcast before. And I know that, recently it's just getting worse and worse what we're hearing from, our clinicians that are actually, in the field practicing with, some of the reimbursements and things like that. So tell us a little bit about, defining this ecosystem. You obviously just kind of gave us a high level view. Where do you think there's opportunity to, get this to be more affordable and accessible for everyone?
So on the macro level, it is for providers to start directly negotiating with the people who are ultimately paying the bill. And that is not the networks like it used to be. It's large employers. You're seeing in the state of California, more and more employers, even the state has taken things into their own hands and is, really working to cut out as many middle people that are involved as possible. I think that, the concept is called direct contracting. It's, I appreciate that we're in a world now where things are so nationalized and, hospital systems keep growing and expanding their footprint from a corporate standpoint, right? I mean, I'm a big believer in, businesses growing and giving back to the economy. But they also need to understand where their patients are that they're servicing at the micro level, right? And understanding in their own zip code, who are the patients that are coming to them and who pays their premiums. Do they have a lot of individuals that are part of the ACA? Or are they, more than half of America is insured by a company, by employee benefits. And so it's figuring out, how do you get rid of these insurance companies that have gotten in the middle and go direct to the payer? You see that when you talk about other areas of insurance, right? You see that if you get into a car accident, right? The higher responsibility we take on as a consumer, right? If I'm buying a car, I'm going to look at what is the monthly premium versus what do I have to spend in the event I get in an accident, right? And so usually people will go for the cheapest policy, but if they get an accident, they're spending a lot of money up front, right? That deductible is going to be high. Well, if I have a high deductible, I'm going to shop what service provider I'm going to spend that portion of my money, right? If I know I have to spend $10,000, I want the ability to go direct to who I'm paying the bill. And that's the same concept that I hope providers listening to understand. These employers are taking on more and more responsibility of their own health insurance for the patients that the employees are giving it to. So it becomes, how do you make more of a community effort and making sure that the people paying the bill, the employers, we're talking about, in California, you've got the studio exec, whoever's giving employees insurance, right? Your top employers, that they have direct access. And that's done through a lot of consultants that are out there in the country, but we're seeing the most needles moved because creative plan designs are coming from it.
Interesting. So it sounds like you've helped, I know, a lot of different companies and healthcare startups kind of pay your attention. Tell us a little bit about how you've helped do that and
Well, because
obviously
you're in California, and I'll just give
yeah.
you a really cool company that I'm working with right now, and
Tell us.
it just explains how we're working to try to fight the system. So I have a client I work with, their name is Leafwell. They're in the medical cannabis space. So, where I know that California, it's legal both medically as well as recreationally, in the medical side, which is really where cannabis began getting the momentum it's gotten in the United States.
Mhm.
If you go to a doctor today and you say or the doctor sees, oh, you have high blood pressure. If they said, Stacey, I'm going to write you a script for high blood pressure. Take this to the pharmacy and get a high blood pressure drug. You would say, well, there's like 100. Which one, doctor, should I write? Like, write the name of which one you want me to get. And that's how it works in traditional medicine.
Mm.
In cannabis, it doesn't work like that. The doctor can say, Stacey, I'm going to write you for cannabis. You go to a dispensary and you say to the, bud tender, I have migraines. Can you please tell me which, and this is not a doctor giving it to you.
Mhm.
So what Leafwell has done is they have created a network of physicians throughout the United States. It is lethal medically in 38 states, but in all 50, there's forms of CBD, et cetera. And they have created, I shouldn't say we, they have created like a telemedicine way to talk to a physician, explain what your diagnosis is, and get medical advice as to what product you're getting from one of their network of dispensaries throughout the country. What they've done oh, sorry.
Yeah, that's neat. So it's directly the physician talking to, the person that will
A
be giving
patient.
them. Yeah.
And they have, treated now more than 500,000 patients. They have seen, the results of people going off traditional pharmacology. So why they brought me in is because now we're going to payers. Now we're going to health plans. Now we're going to companies that insure people and saying, wouldn't you rather spend substantially less money on somebody who wants medical cannabis versus thousands of dollars on pharmaceuticals that don't even work as well as maybe something that's more naturopathic? And
Mhm.
that is how we bridge the gap. And then we have providers involved that are getting reimbursed for the time that they're spending with the patients, and we're redirecting care. So that is like an example of a startup. They're not a startup anymore. They're
Yeah.
certainly a large company, but they are new in the insurance side. And it's continuing to bridge the gap with, the providers and a new way to handle a patient's care.
I love that. Such an innovative way and a great example to bring that to life. So thank you. And so I know that you were talking about kind of how complex things can be with the pharmacy benefits, and these funded plans are usually kind of complicated. So what are some of the biggest misconceptions that people have around, PBMs and, this kind of self-funded world?
So the biggest misconception, so you're going to talk, so that's more of a business minded question, right? Because I would say the average American, these words probably go over their head because, nobody really thinks about self-insurance or, the behind the scenes of the health insurance world. But the biggest misconception is that only very large employers can do this. When in fact, really, I would say unless your state specifically doesn't allow it, you can have as little as 40 or 30 employees and self-fund, a portion of it. We're never putting an employer at 100% on the hook for all the medical claims. There's always some kind of gap policy or reinsurance in the background or catastrophic. But there is a strategy for every company in America, I would say over, that 30 or 40 employee benchmark. If they, want to explore and how that works, just to bring this back to your audience, Stacey, is it works with direct contracting with the hospital systems and the physician networks that are in their own backyard. And probably where this ties into Pacific, because, again, I appreciate you hosting me, is, for employers that may have people in other states or where the partnership comes, that's where the growth of these, clinics comes from because they're seeing patients that they're directly now aware of. And it's a really exciting time. You know, where people are going to start hearing more and more about the PBM industry and why there it is becoming a little bit more well known than it used to be for two major reasons. One is Mark Cuban, not a household name, but close enough, right, to somebody that can advocate. You know,
Yeah.
he owns with being owning the Mavs, being on Shark Tank.
Yeah.
He has identified, so many problems on the payer side, especially in the pharmacy industry, that he has taken it on himself. And, the more I have friends, who for 20 years didn't know what I did, and then all of a sudden Mark Cuban is talking about affordable prescriptions. I have people say, "Is that what you do?" And I'm like, kind of, but yeah, that's the PBM space. He's in my world. And the second reason, Stacey, that people are going to, if they're not already, be very aware of the role the PBM plays is because of what's called GLP-1s. If you're not familiar with the term GLP-1, Ozempic and all the other, medications that were designed for type 2 diabetes, but are being used for, it started with weight loss because it works. But we are seeing a huge uptick in people that are taking GLP-1s. In fact, 1 in 3 Americans knows somebody, if not themselves, that is taking a GLP-1. And I always like to ask,
Yeah.
do you know anybody in your life that has taken one? So there you go. There's my statistic proven. And so because of that, who pays for that? The pharmacy benefit manager, who says no when they're not going to cover it. It's the pharmacy benefit manager. And so I'm not going to say whether that's good or bad. I'm just suggesting that that's who's controlling the shots today and which one you can get and how you get it. And so that is like the first time in my career that people are suddenly like, oh, it's not my insurance company. It's the PBM who is calling the shots. And so, that is, the misconception is that, my side of the industry are the bad guys. And it's funny because my side of the world would say the providers are the bad guys. No one's a bad guy. Everybody deserves to get paid. Everybody deserves to, grow. But truly, the providers are the ones that need to be to me, the highest compensated because they're the ones doing the job that average people like myself can't do. But we've had so many people in so many areas manipulating our healthcare system that's where it's drawing attention away from. So I'm trying to bring it back to the provider, bring it back to the patient, and figure out a way that we can afford it for as many people as possible.
Well, that was enlightening. I was like, I never understood until you kind of put all those pieces together. And yeah, I have heard about Mark Cuban and all the work that he's doing in the space to make, prescriptions more affordable.
Yes.
So and tell us how much could potentially a company save, like if they were to go direct to this model. I mean, you talk about companies that are
Oh,
40 more in size. What are
oh my
this?
goodness. I mean, so if you think of the health insurance premium, everything depends on, if you have everybody in your whole company taking a GLP-1, that's a whole other story because those are, GLP-1s can run upward of $1,000 per person per month. So they're very expensive. But a typical company can save anywhere between 30 and 40%, just by looking at all of the layers that are in there and creating direct relationships. And again, it just depends where in the country you're based. But certainly in California, a tremendous amount where healthcare and providers are, there's not a shortage.
And how would somebody, if you're, let's talk about on the company side, and then we can talk about on the physician side, how would you go about doing this? Is it getting in touch with someone like obviously yourself to know, okay,
Yes.
for the next steps?
So absolutely. So you can reach out to me. There's a whole world of health insurance consultants out there that I am connected with. I can give you, just one world to look into. It's called Health Rosetta. That's a whole organization that is consultants who have, kind of taken an oath, if you will, to do the right thing by employers. The problem in healthcare is also who sells it. That the way brokers traditionally have been compensated is the more you spend as an employer, the more they get paid. So how much is a consultant really going to shop the marketplace to take a decrease in pay. And what Health Rosetta kind of came in and said is that that's not how brokers should be compensated. They should be paid like your accountant. I mean, imagine if your CPA got paid on how much taxes you paid the government. That would like not be a good deal for you. Like it would, right? That's essentially how the majority of Americans, are getting their insurance from somebody selling it to them. It's not the right way. It should be done in an hourly or project based on the employer's goals. And then, if it, and I say this especially, again, leaving this Rev Cycle conference, hospitals and providers that are listening, if you have people on your board of directors that own companies and you're not doing something together, like that's the lowest hanging fruit because you've got people committed to, the vision and mission of your healthcare system. And why would you not be working together so that the employees that board member has, this is an employer's second highest line expense after payroll. So we need to start paying attention to it. And then if the employer side gets fixed, then we fix the individual side, right? And we make it so that our 28 and 29-year-olds, number one, can afford to go on a company's plan or can afford, go on the ACA and not need such high subsidies. And, and because the healthier people are that are insured, the more we have resource for the people who really need it.
I appreciate that because I think just even talking about how much, they can save as a company and then ways that they can, obviously get a hold of you and the brokers you just mentioned. And then for the physicians listening, I think in the hospitals and healthcare systems, which, we know as part of our audience, that is a really great idea is to start with, okay, the companies that may be, like you're saying, who's on their board and what companies, and using that as the first way to go to market. And I would be, similar for, some of the smaller physician groups, a great way to kind of look and see, are there different, different companies we can tap into?
And even within the physician groups, it's figuring out, who are you paying and for what? I can use a great example of my father. My father is a private practice physician in the Detroit area. And, most of his staff chose to see him as their family doctor. They didn't have to, but he was able to figure out a way to, only pay for if they needed to go to a hospital or, pick a different policy and create his own little mini self-funded plan for things he could write off as a business expense and not pay somebody else to pay him back because it didn't make sense, right? And bill for something that could be done internally by his team and other physicians. So it's just getting creative and it's having, if you don't, if you're a provider listening and you are part of a group or, an anesthesiology practice or anything where you can control, multiple offices or a population of employees, and you have a consultant that is not at least talking to you about these things, that's who I hope you reach out to me and I will find you the right person because there are so many great people. I probably could name somebody in every state that I have worked with in my 20-year career that is, will do you right and, find a way to work within the partnerships that make sense.
On that note, I know obviously this the pharmacy benefit landscape is always, it's rapidly changing. There's different laws, transparency laws, things like that. What is something that you are excited about or cautious about right now within that landscape that you want to make our listeners?
I'm cautiously excited about how much we're talking about in Washington. The name of it, I don't know. I mean, Trump RX, we're just going to let him have it. But I think that the more conversation and this was part of the Biden administration too, by the way, this has been, drugs have to get less expensive. We have to continue to have conversation. And so I don't care if it's a Republican. I don't care if it's a Democrat. I care that it's being talked about. So I am excited. We just saw Pfizer start working to get some less expensive medications to this marketplace where Trump RX will launch, hopefully Q1. I'm not as excited with the drugs that they first came to market with. I think we need a GLP-1 strategy desperately. I'm also excited that Trump has brought awareness to how drugs are so much cheaper in other countries and it's at our expense. We pay for the research here in the United States, yet other countries are getting those same drugs at a fraction of the cost. And he's trying to make that not, allowed. That is exciting to me. One of my clients, I do a lot of drug importation from Israel because it's less expensive than paying the United States prices. By the way, I have that list too for listeners who are, struggling with out-of-pocket costs. But, as much as like, I love that, we should have those prices here in the United States, and we don't. And so we are, thrilled that other countries work with us and, send our medications back to us at the price we should be paying to begin with.
Great insights there. Tell us, I know we're getting to the end here, so I just wanted to, obviously, you really have, been a leader in this space. What type of legacy do you want to leave, obviously, with all that you're doing? What's the impact that you really are always thinking about that you want to make in the healthcare industry?
That people understand how their healthcare works. It is so complicated. And I also don't want people to think that if they have a card in their wallet that doesn't have a name that's today a household name, that they think that their insurance sucks. Because it's not. We need to get to a place where it doesn't matter who is, paying a high claim. You know who your provider is, and you know what you get to go do with that provider. That to me is what will change everything and, have more healthy people having that access. And, again, the legacy here is obviously accessible and affordable healthcare. And it's being a part of helping change the narrative of how we get there.
Well, thank you so much for bringing awareness to this topic. And really, it's something that, I don't think is talked about a lot. And I don't think a lot of people have all the knowledge and wisdom and insights that you do. So, Rachel, tell our audience once again how they can get a hold of you and contact you and work with you.
Absolutely. LinkedIn is probably the easiest way to get me, Rachel Strauss. You can also find my company, PBM Princess, or you can get me Rachel at rachelmstrauss.com.
Perfect. Well, thank you so much, Rachel, for your time and being on the Doc Lounge podcast today.
Thank you, Stacey. It was a pleasure to be here.
Thank you to all of our listeners. If you would like to be notified when new episodes air, make sure to hit that subscribe button. And a big thank you to Pacific Companies. Without you guys, this podcast would not be possible. If you would like to be a guest, please go to www.pacificcompanies.com. Thank you.